Good evening to everybody. On behalf of IAP TNSC, I welcome one and all for this postgraduate case presentation. And now we'll start with a pediatrician prayer by Dr. Gopal Subramaniam, IAP Treasurer.
Thank you, sir. Good evening, one and all. We'll start today's DIAP program with the pediatrician's prayer. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தன் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நல்லம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருளையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. It's my duty to welcome our chairperson for this case presentation. Our chairperson, Dr. Riaz Ahmed, is a gastro DM gastroenterologist. Is a former professor and head of the Department of Pediatrics, Government Calicut Medical College. Presently professor and head of Pediatric Gastroenterology, KMCT Medical College, Calicut, Kerala. He is a well-known author for the textbook of Pediatric Gastroenterology and Hepatology. And another one is a review of pediatric, frequently asked questions in pediatrics also. And he is a well-known teacher as well as author. I welcome Dr. Riaz sir. And next I welcome Dr. Abhiram Lada. He is currently associate professor of neonatology at SRMC, Ramchandra Medical College. She has currently she's having awards and positions like associate editor, Cochrane Neonatal Neonatology, and a Young Researchers Award from Indian Academy of Pediatrics. She's having a lot of publications, almost 39 publications, including 22 original articles, and author chapter in many neonatology textbooks. And so I welcome Dr. Abhiram Lada. Dr. Ramesh is currently associate professor, and he has done DM neonatology, and he has author of many chapters also and articles he has published. Currently he is associate professor PhD Medical College. I welcome Dr. Ramesh. So on behalf of IAP, I welcome PhD Medical College students. Today's presenter Meenu Priti, and another only student Madhumida and Kriti Nair for this wonderful case presentation. And almost it is we are almost 11 months now, 40 case presentation by postgraduates, and every week we are doing all India level, and it's well appreciated by our local as well as national teachers as well as students. So once again, I am behalf of IAP TNSC, welcome one and all. I welcome today's judges, Dr. Jaundice Shankar from KKCT, Dr. Larasi Madam from ICGH, Dr. PRC sir, P. Ramachandran sir from SRMC, and Dr. well-known teacher and former professor of pediatrics, JIPMER, Dr. S. Srinivasan sir, also one of the judge. And I welcome our Gopal Subramaniam, Joint Secretary Tirumurugan, and our President Dr. Ismail sir. And in these few words, I request our today's chairperson, Dr. Riaz Ahmed sir, to tell a few words regarding this presentation, and you can start the proceeding.
Am I audible?
Yes, sir, please.
Yes, sir.
My respected and beloved teacher, Guru and mentor Srinivasan sir, my dear colleagues of Tamil Nadu IAP, good evening to you. I would like to profusely thank Professor Rajendran for giving me the privilege to be a part of this exciting PG teaching program. We shall be discussing two cases. The first one is a short case on a neonate with unconjugated jaundice for about 30 minutes. This will be discussed by Dr. Abhiram and Dr. Ramesh Menon, and I will also be chipping with some questions. Then we'll have a long case discussion on a 90-day-old baby with cholestatic jaundice. I'm very happy and proud to welcome to our midst the excellent moderators, Dr. Abhiram Lada and Dr. Ramesh. The cases will be presented by Dr. Meenu Preeti, who I understand is one of the best postgraduates of PhD Medical College. In fact, I have very fond memories of PhD Medical College, mainly because my best friend, Professor John Mathai, was the professor and head of pediatrics, as well as a pediatric gastroenterology for a very long time in PhD Medical College. And I belong to Palgad, and we have got so many relatives in Coimbatore. Now, towards the end of the session, we shall have a quick revision in which I shall try to share my experience with cholestatic liver disease. So this is going to be an interactive session, and I request the postgraduates and the participants to as far as possible, write your answers in the chat box. Okay, all the best to you. The first case will be presented by Dr. Meenu. It's over to Dr. Meenu.
Good evening, everyone. I thank IAP State Chapter and the Department of Pediatrics PhD Hospital to providing with me this great opportunity. I'll start my presentation.
It's going to be a short case. Okay.
Baby of Vishnupriya, day 7 of life. This baby was born to a primary mother at 39 weeks, 4 days, with a birth weight of 2,500 grams, 540 grams by emergency cesarean section. The informant was mother and her reliability was good. The mother said that the jaundice was noted on first postnatal day, and she was told by the doctors that the baby had high bilirubin, as the mother and the baby had different blood groups. That is, the mother had O positive and baby had A positive. Because of high bilirubin, the baby was started on phototherapy at bedside, and serial bilirubin monitoring was done during phototherapy. Mother said that the baby had poor feeding and activity after starting on phototherapy. As there was persistently high bilirubin despite phototherapy, baby was shifted to NICU. At NICU, the baby was examined by the doctors and was told to the mother that the baby's sensorium is normal, and they were planning to continue phototherapy along with IV fluids. Phototherapy was continued for further 2 days, and the baby was off phototherapy on day 4 of life. Phototherapy was restarted on day 5 as bilirubin had increased again. There was no history of high-colored urine, pale stools, or high-pitched cry, posturing, or seizures during any course of this time. At present, baby is off phototherapy since today morning and taking a direct breastfeeds well, about 10 to 12 times a day, each feed lasting 20 minutes. Baby is having adequate sleep after each feed and passing urine and stools adequately. And mother said that the baby started to gain weight now. Coming to the past history, this child is a only child of the non-consanguineous parents, and with family history, there is no family history of jaundice, hematological disorder requiring blood transfusion, or splenectomy, cholecystectomy, or neonatal deaths in the family members. In antenatal history, it was a booked and immunized case. The baby and the mother was on iron and folic acid tablet regularly. There was no history of fever with rash, hyperemesis, or radiation exposure during the pregnancy. And there was no history of pregnancy-induced hypertension, gestational diabetes mellitus, anemia, hypothyroidism, or urinary tract infection in mother. There was pre-labor rupture of membranes 4 days prior to expected date of delivery, and she was admitted in our hospital. The emergency cesarean section was done due to fetal distress on 27th of August, and she delivered a male baby, cried immediately after birth. The baby passed meconium and urine normally on day 1 of life. Coming to the general examination, baby sensorium was asleep and calm, skin appears bleached, and there was no pallor, cyanosis, edema, with vitals, temperature 36.5 degrees Celsius, peripheries were warm, heart rate 154 per minute, peripheral pulses well felt equally, and capillary refilling time was less than 3 seconds. Respiratory rate 52 per minute, regular rhythm, no retractions or grunting noted. Anthropometry, birth weight of the baby was 2,540 grams. It was small for gestational age according to the intergrowth chart, and current weight is 2.41 kg. It is 5.1% loss since birth weight. Length of the baby is 48 centimeter. Head circumference 31.5 centimeter, less than third centile, but it falls on -2 standard deviation. With new Bellot score, the gestational age of the baby is estimated to be 38 to 40 weeks. This is the intergrowth chart where I have plotted the birth weight of the baby, which falls on the third centile, and length of the baby that I noted today, that is falls between the 10th and 50th centile, and head circumference, which falls below the third centile. Coming to head to toe examination, head is small in size, AF at level, admit 3 fingers. There was no capillometoma, subglial bleed. Cord looked healthy, and skin external genitalia was normal with bilateral testis distended and palpable at the scrotum. There was no petechiae or vesicles noted in the skin. Limbs were normal, no syndactyly or polydactyly noted. Systemic examination, abdomen was soft, not distended. There was no liver or spleen or any mass palpable. Bowel sounds heard, and respiratory system wise, the chest wall is symmetrical and movements are equal on both sides. There was abdominothoracic breathing, bilateral air entry equal and no added sounds. Cardiovascular system, there was no precordial bulge. Apical impulse was felt on left side. First and second heart sounds heard in normal intensity and no murmur. Central nervous system, baby was awake and active while examining, and the cranial nerves are normal with neonatal reflexes, rooting reflex, sucking reflex present, Moro reflex complete response was there, and palmar and plantar grasp present, placing and stepping reflex present, asymmetric tonic neck reflex present. Summary, this term, small for gestational age baby, born to non-consanguineous parents with a birth weight of 2,540 grams, developed jaundice on day 1 of life, requiring phototherapy for 3 days, and now has rebound hyperbilirubinemia, requiring further phototherapy. He has no features of bilirubin encephalopathy, with probable etiology being OA incompatibility. Diagnosis, it's a term baby, small for gestational age, neonatal jaundice, probable etiology is OA incompatibility.
Dr. Meenu, what do you think the problem the baby is having? Can you once again justify your diagnosis?
So as per the history, mother told that mother and the baby had different blood groups. So they had initiated, they have noted jaundice on the first day of life itself, and which required even phototherapy for treatment. So probably it would be an OA incompatibility which have caused the hemolytic anemia in the baby.
What are the features to say that this baby has a pathological jaundice?
Pathological jaundice, as the baby had developed jaundice that requires phototherapy even on the day 1 of life, and that level was high enough to require treatment with phototherapy.
What other features can be there to, what are the other features of pathological jaundice in a newborn baby?
I said, if the jaundice is prolonged for more than 2 weeks and the rate of rise of bilirubin is 0.2 milligram per deciliter per hour, and the range that requires the bilirubin level that requires phototherapy, and features of bilirubin encephalopathy, if anything is present.
Okay, so how you are going to proceed with this baby? So since if you are seeing the baby on the first day, okay, so now the baby has come, has received some treatment. If you are seeing the baby on the day 1 with a jaundice, okay, with the setting of mother having a O positive blood group and the baby O positive and the baby having A positive blood group. So how you'll proceed with the management?
Once I identify the jaundice, we have to send for lab total serum bilirubin levels, and we have to do confirm the baby's blood group, and direct Coombs test would be done to look for whether incompatibility is there. And after seeing the serum bilirubin level, if it requires phototherapy and falls on phototherapy range, we have to start the baby on phototherapy. And we have also proceed with other investigations to look for evidence of hemolysis, like complete blood count, in which we can see the hemoglobin status of the baby, and peripheral smear, where we find the features of acute hemolysis like microspherocytes, polychromasia, nucleated RBCs are seen. And serum albumin should be measured. This is because the serum, if serum bilirubin albumin is low, it may increase the risk of bilirubin encephalopathy. And a reticulocyte count should be done to support our evidence of hemolysis.
So since you committed, just I want to ask you, how you think the albumin level is going to affect the management, or how in what way it's going to affect the baby?
If there is hypoalbuminemia, it will cause increase in the free bilirubin, which may cross the blood-brain barrier easily, because albumin-bound bilirubin usually do not cross the blood-brain barrier. The free bilirubin crosses the blood-brain barrier and causes damage to the brains.
Okay, very good. So other than the investigations, what else you would like to see the baby when you are seeing a baby with a suspected pathological jaundice? Clinical, I think you already mentioned in your presentation. Just for the sake of highlighting, what other features you would like to see clinically before sending the investigations?
Yes, sir. Clinically, we have to look for any capillohematoma subgaleal bleed, which may increase the bilirubin level because of the absorption of the blood from the bleed. And we have to look for any signs of infection, like if evidence of intrauterine infections like petechiae and congenital cataracts are there, or hepatomegaly and splenomegaly also should be evaluated.
Just related to your presentation, since you are suspecting a OA incompatibility, what clinical manifestations will indicate a clue that there may be some incompatibility related isoimmunization going on?
Clinical clues, sir?
Yeah, clinically. So, what will happen when there is an incompatibility related isoimmunization?
Hemolysis will have.
Excellent. So when there is a hemolysis, what clinical features you will be looking for?
Baby will have jaundice and associated, even if anemia is severe, the baby may present with pallor.
Okay,
and
good.
acalric urine will be there, sir.
Okay, in the abdomen examination, you mentioned in your
hepatomegaly and splenomegaly may be there.
Yeah, clinically you have to look for the splenomegaly, and maybe the liver may be enlarged. There may be pallor. So these are though hepatosplenomegaly may indicate an intrauterine infection, the common scenario which we face is because of an hemolysis due to blood group incompatibility. So the baby presenting with the jaundice, pallor may be there or may not be there, and the hepatosplenomegaly, if it's there, it may be a strong clue for hemolysis. So these are the clinical features. In addition to that, how you will assess the severity of jaundice when you are seeing the baby for the first time with a significant pathological jaundice? How you will assess the severity of the jaundice?
Signs wise, we look for features of like encephalopathy, whether there is poor suck and lethargy, and any abnormal posturing, seizures are there. And with like examination, we look for how severe the jaundice by using like Kramer's rule, like how extent the icterus is noted in the baby's body surface. Up to the face, if it is there, it's 5, and up to the upper chest, it's 5 to 10, and up to upper thighs, it's 10 to 15, and below the knees, it's 15 to 20, and if palms and soles are involved, it's more than 20.
Okay, very good. So you should, jaundice is a life-threatening. Sometimes it can be life-threatening, or it may be impairing the quality of life at a later age. So if you are suspecting a pathological jaundice, especially if you see a baby with a significant clinically visible jaundice on day 1, you should be very alert. So the baby may slip into an encephalopathy at any time. So you should send the clinically evaluate the jaundice, and you should start management, and you should send the investigation simultaneously. That's very important. Okay. Yes. And how you will assess, so after sending the investigations, and how you will interpret the results, and how you will start the management.
Looking at the serum bilirubin level, and we plot it in the AAP charts. If it is on the phototherapy range, which requires phototherapy, we'll start phototherapy. If it is above the phototherapy range, we have to look at the exchange chart, and if there is a need for exchange transfusion, or if it is like near exchange within the 2 milligram deciliter difference from the exchange cutoff. If it is there, then we have to start on intensive phototherapy. Otherwise, we'll start the baby on double surface phototherapy, which requires alone phototherapy alone. And we look for the evidence of hemolysis. If that supports our diagnosis, we will continue with the phototherapy and serially monitor the bilirubin for the response with phototherapy. If it is just near the phototherapy range at 6 to 8 hours of after starting phototherapy, we repeat the level. If it is like near exchange, we have to do it at a shorter time, like after 4 hours, like after the starting phototherapy, to look for a response. If it is still persistently increasing, or it crosses beyond the exchange level, then we have to proceed with the exchange transfusion.
What are the risk factors you will consider while using this chart? What are the informations you need to use this AAP charts?
First, the chart has 3 lines, so we have to first note the risk of the baby, like whether the baby falls on low risk, medium risk, or high risk. This risk categorization is based upon the gestational age along with the risk factors they have considered. Like risk factors in the sense like isoimmune hemolysis, hypoalbuminemia, asphyxia, acidosis, temperature instability, and whether the signs of encephalopathy like present.
Okay, so it has some clinical features too. Okay, so when you're examining a baby, you should also look for these clinical features. You have to look for temperature instability. You have to look for the features of sepsis. You have to look for the baby sensorium. So those factors also to be used to be examined when you are assessing the severity of the jaundice. Okay, yes. Yes, sir. Dr. Abhiram, would you like to ask some questions?
Yes, sir. Thank you, sir. Excellent presentation. Congratulations. So you said the baby had poor feeding and poor activity, in your history. So what do you think is the reason for it?
That may be because the mother noticed, like after starting on phototherapy, the baby was not sucking as before and seemed less active. It may be because of the high level, which may go up to near exchange or exchange, that may present as acute bilirubin encephalopathy in early stages. But after going for NICU, it was confirmed that the baby was neurologically normal. So only they continue on phototherapy and along with fluids like mother too.
Okay, good. And in the examination, you said regular rhythm, no? So usually in neonates, we don't say regular rhythm because they have periodic breathing.
Yes, ma'am.
Okay, so don't use the word regular rhythm.
Yes,
and don't say precordial bulge also, because even in a baby with large VSD or PDA, precordial bulge will take time to develop.
Yes.
So your newborn will not have a precordial bulge.
Yes.
Okay, and you said cranial nerves are normal. So could you please shortly summarize how did you examine the cranial nerves?
Yes, ma'am. First cranial nerve was not assessed. With the second and 3, 4, 6, the fixation of objects, it was momentary. Baby was momentarily fixing, then showed bright objects like red color ball we showed, ma'am. And with the 5 and 9, 10, rooting and sucking reflex was present. With 7th nerve, there was no facial asymmetry while baby was crying, and the folds and the wrinkles were equal on both the sides. With the passive movement of neck when turned side to side, there was no resistance, so that we could say 11th cranial nerve was normal. 12th cranial nerve, like the baby was crying, there was not like atrophy or any restriction of movements noted in the tongue.
Very good. Eighth now?
Eighth nerve, when we tap near the cot, the baby had startle reflex. And we did more. This is for cochlear component, and for vestibular component, we checked at Morose reflex, and it was complete.
Very good. So only the vision, usually we don't use red ball for neonates. We use black and white patterns. Okay, because that is the first thing they can see.
Yes, ma'am.
Okay, very good. So in ABO incompatibility, only if the mother is O positive, the baby will develop hemolytic jaundice, no, not otherwise. Why is it so?
Because the mother, only in O blood group, people will have antibodies of anti-A and anti-B. If A positive means they will have anti-B antibody.
Okay, for example, if the mother is A positive and baby is B positive, so there is incompatibility, isn't it? But the baby does not develop hemolysis. Okay, so the naturally occurring anti-A, anti-B antibodies are IgM type. Okay, so A and B group mothers will have only IgM type of anti-A and anti-B antibodies, which do not cross the placenta. Only O group mothers produce IgG type of anti-A and anti-B antibodies, which crosses the placenta and causes hemolysis.
Yes. Yes.
Okay, so why there is no hydrops in ABO incompatibility? The baby doesn't develop hydrops, no, in ABO, whereas in RH we have seen many babies with hydrops. Why is that so?
The hemolysis is not as severe as seen in RH isoimmunization.
Very good. So why is it not severe? So because A and B antigens are present in all the tissues. Okay, so they are not present only on the RBCs. So even if the antibodies cross the placenta and come to the baby, so they'll get neutralized in the peripheral tissues itself before they could reach the RBCs.
Yes,
okay, so that is why babies don't develop hydrops. Okay, so you said that there was no history of jaundice or this one cholecystectomy in the family, no? So why did you ask that question?
The inherited hemolytic conditions may be present in the family, so that only we ask for family history of blood transfusion and splenectomy and cholecystectomy.
Okay. So what are the hemolytic anemias that can present as neonatal jaundice?
Neonatal jaundice, hereditary spherocytosis, deficiency.
Okay, so which all hemolytic anemias don't present in the newborn period?
Beta thalassemia and sickle cell anemia.
Excellent. Okay, so regarding RH isoimmunization, why does it not present in the first pregnancy?
The anti-D caused the mother should be sensitized first, ma'am. The sensitization occurs only when the mother is exposed to the RH positive blood group. That occurs when like abortion or after the first pregnancy.
Okay, so the feto-maternal hemorrhage happens only during delivery. Okay, so that time only the mother gets sensitized and she'll take a few weeks to develop the antibodies.
Yes.
So that is why the first baby is not getting affected. And what do you do to prevent RH isoimmunization?
We give anti-D.
Very good. So how much is the dose? That OGPG will take care, isn't it? So 300 microgram we give, okay, and 300 microgram is adequate to cover up to 30 ml of feto-maternal hemorrhage.
Yes.
Okay, so if you want to follow this baby up to 2 weeks or 3 weeks, what do you expect at 2 weeks? What complication do you expect in this baby in the next 2 weeks?
In this baby?
Yeah. In any baby with hemolytic jaundice.
Anemia, ma'am.
Very good, anemia. So they may require a transfusion in the 2nd or 3rd week. Okay. The other one is? So they may develop cholestasis because of biliary sludge. Okay, so their bile will be very thick and they may develop cholestatic jaundice in the 2nd week. Okay, what is the reason for SG in this baby?
The mother did not have any history suggesting for SGM, like no PIH or anything. But mother said that she also had adequate weight gain. Like from pre-pregnancy, she had weight gain of 13 kgs during the pregnancy. There was no history suggestive for the cause of SGA in this baby.
Okay. So what is the difference between SGA and IUGR?
IUGR babies are nutritionally deprived even at the intrauterine period itself. SGA babies can be constitutionally small babies also. Need not need that they have to be nutritionally deprived all the time.
Very good. So SGA, you are saying only based on the growth chart. Okay, so in the growth chart, if the weight falls less than 10 centile, you call the baby as SGA. So that SGA may be constitutional or it can be intrauterine growth restriction. So how will you diagnose IUGR?
After birth, we have to see the weight of the baby and plot it now. And if it falls less than the 10 centile, we look whether it is constitutional SGA or IUGR. We check whether it is symmetrical or asymmetrical IUGR using Pondal index.
So growth chart will tell you whether the baby is SGA or not. So growth chart will not tell you whether the baby is IUGR.
Yes, ma'am.
So how will you diagnose IUGR?
CAN score.
Very good. The CAN score is for assessing the nutrition. So if the okay, one is CAN score, and so in the antenatal period in serial ultrasounds, if there has been a weight faltering, for example, the baby's fetal weight was at 50th centile at the 20th scan, and then 30th scan showed that the weight has become less than 10 centile. So if there is a drop in centiles in the antenatal ultrasound, or by clinical examination during the postnatal period, which is by CAN score.
Yes.
Very good, Meenu. I am very impressed. You presented well and you answered all the questions well.
That's right. She's presented very well, Abhirama, and discussed very well by both of you. Now, Meenu, who was the first person to describe? Can I ask a question?
Yes, sir.
Who was the first person to describe phototherapy?
Sir, sorry, sir.
Who was the first person to describe phototherapy? Who introduced phototherapy?
No.
You always speak about various different types of phototherapies, so many types. The first person, in fact, that was not a doctor, no? Abhirama, that was actually Jean Ward. She was a nurse. It was described, if I remember correctly, in 1950 in a hospital from Essex. Okay. Speaking of phototherapy, what is the gray baby syndrome, you know?
The babies who have conjugated hyperbilirubinemia, when started on phototherapy,
This is exactly what happens in the examination. You'll be discussing phototherapy, and then the examiner suddenly asks you about gray baby syndrome. The complication of phototherapy is not gray baby syndrome. What is that?
It's secondary to use of chloramphenicol, sir.
That's right. It's secondary to use. If you are using very high dose of chloramphenicol, maybe more than 150 milligram per kilogram, you may develop this condition. Who was Dr. Gray who described it? Who was Dr. Gray, gray baby syndrome? Who was Dr. Gray who described it? Kriti?
Yes.
Was she a pediatrician, neonatologist, gastroenterologist? Dr. Gray? Anybody? Yeah. Yeah, actually, Gray was not a doctor. Gray was not a doctor. Gray is the shock. These babies develop shock. Okay, so they develop a gray or ashen color. It's because of that it's called gray babies, not because it was described by Dr. Gray. What is vigindiphobia? Mean what is vigindiphobia? Head of vigindiphobia. I'm sure that present excellent neonatologists like Abhirama and Ramesh will not be frightened of that. But the old generation neonatologists, they're frightened of what? Vigility means, phobia means fear. And vigility means 20, fear of 20. Am I right, Abhirama? So whenever the serum bilirubin used to cross 20, decades back, they were frightened, the pediatrician neonatals were frightened, they used to do an exchange transfusion. Actually, it's not, there are other criteria for doing exchange transfusion. Okay. What is heliotherapy? You know what is heliotherapy?
Use of
Heliotherapy treatment with the sunlight, sir.
As a pediatrician, will you recommend heliotherapy or not?
No, sir.
You will
No, sir.
recommend or not? Why not?
No, sir.
Why not?
Because it might cause dehydration, overexposure to sunlight, and can aggravate underlying jaundice.
That's also another thing is that the parents may have false sense of security also. They'll feel that everything will be cured by sunlight. In fact, a few years back, I had one of my residents' daughters. The grandmother asked the mother to expose the obstetrician asked the grandmother to expose the baby to sunlight, and the baby promptly developed sunburns. So that's quite possible. Okay. Anything else? Do you know of any other blood group, minor blood group, which may cause severe hemolysis apart from the Rh and ABO? Which minor blood groups may cause severe hemolysis?
Kelland.
Yeah, the tip for that is Kell kills. Kell kills. Okay. What else is the problem with Kell? Apart from jaundice, there may be some other problem with Kell group, Kell incompatibility. It may suppress erythropoiesis. It may suppress erythropoiesis. In addition to jaundice, there can be anemia also. Can you mention one a definite contraindication for phototherapy? Clue? You want a clue? It's a genetic disease. Which genetic disease? Goes by the name of a German scientist. What is Gunther's disease? Head of Gunther, G-U-N-T-H-E-R, Gunther's disease. It's a very important topic for pediatricians, for residents in pediatrics, but they usually don't like it. It's a tough topic. What is Gunther's disease? G-U-N-T-H-E-R. Suppose the baby has got bullous lesions. This baby, you're about to start phototherapy, and you see that the baby has got multiple bullous lesions. This is congenital erythropoietic porphyria. Congenital erythropoietic porphyria is one of the definite contraindications. Okay. What else? Abhirami, you want to ask something more?
No, sir.
So shall we wind up this session?
Yes, sir. Yes.
Okay. When you are ready for the next case?
Yes, sir.
Can you stop sharing?
Yes, sir.
Could you please stop sharing? Yeah. Okay, so now we shall discuss a baby with cholestasis. All right, Minu. So what's written in black is what Minu has sent me, and my questions will be in red letters.
Yes, sir.
Okay, so start.
Kartika, 9 days from
Yeah. So what is the significance of gender in cholestatic liver disease? I will be asking questions right from the word go.
yes,
What
sir.
is the significance of gender? Is it important?
Yes, sir. Female gender or prepone to some conditions like biliary atresia, choledochal cyst, like that.
So the clue is that both surgical causes, choledochal cyst as well as biliary atresia, that's more commonly seen in females. It's not an absolute criterion, but you can see that females are more predisposed to develop the surgical cause. What are the countries with the highest incidence of biliary atresia in the world?
Taiwan and Japan.
Yeah, Taiwan and Japan. You know that the stool card that is actually designed from Taiwan. Taiwan, in fact, has the highest incidence. Okay, right? You know.
This was the only child of non-consanguineous parents.
Okay. Then what is the relevance of consanguinity in cholestasis? Suppose this child is born to consanguineous parents. So what is the relevance, importance of consanguinity in cholestasis? What are you worried about?
Because inherited conditions
Like
tend
what?
to occur in consanguineous
Like
parents.
what? Like what?
Like autosomal recessive conditions like galactosemia, tyrosinemia, and hereditary fructose intolerance.
And that's so many conditions. Speaking of tyrosinemia, I think a postgraduate should be more
Tyrosine-
careful. Which type of tyrosinemia?
Type 1.
Type 1.
Remember that only type 1 tyrosinemia causes liver disease. What is type 2 tyrosinemia? It's known as Richner-Hanhart syndrome.
Hanhart.
Syndrome doesn't cause liver disease. It causes only skin lesions and corneal lesions. Okay, so there are so many conditions present which are inherited as autosomal recessive. Okay, continue, Meenu.
The mother came with complaints of jaundice, high-colored urine, and pale stools from first week of life onwards.
Right from the first week of her life, this baby had high-colored urine and pale stools.
Golden yellow.
Just a minute. Okay, what is the color of normal urine?
Light yellow.
Golden yellow, sir.
Straw color.
Straw color. Okay, that's what's given in Hutchison. What is this?
Straw.
This is straw. What is straw? Once I asked my undergraduate student, what is straw? Then he said, sir, you know the straw which we drink Coca-Cola. It's not Coca-Cola. Okay? Straw. They're all fond of Coca-Cola. So it is straw color. It's also known as hay or straw. Or another description given in Hutchison is amber color. Okay. Now, what is it due to? Why is it? What is the color due to? Why is it straw colored?
Urobilin.
Urobilin within the urine.
Urobilinogen is colorless. Okay, urobilin, or it's also known as urochrome. Urochrome or urine. What is the significance in diarrhea? In acute diarrhea, is it significant? The color of urine, is it significant in a child with acute diarrhea?
It will be concentrated in diarrhea.
Concentrated urine. So you get a high-colored urine. It's a marker of dehydration in a child. So whenever you are presenting a child with a diarrhea, always ask the mother about the color of the urine as well as whether it is oliguria or not. So this is what happens when a child has got acute diarrhea. The urine becomes concentrated. Okay. Okay, right,
Baby was taken to the nearby hospital due to the high-colored urine and pale stools at first week of life.
Okay. The doctor reassured that it will disappear gradually. That is very interesting. Now, what's your comment on this? Doctor reassured that this will disappear gradually.
The mother went to the hospital during first week of life, sir.
What's your comment? Will it disappear gradually?
No,
Remember that high-colored urine, pale stool. Very significant, very significant. You should never ignore the mother's complaint that the baby is passing high-colored urine and also pale stools. This definitely indicates that he's got a serious problem. You should never, that should be given, that should be taken very seriously. So this should not have been done by the doctor. So here you see a typical high-colored urine and pale stool.
No complaints of abdominal distension.
So in children with biliary atresia or cholestasis jaundice, one of the complaints will be the child develops abdominal distension. So the next question to you, what are the three major causes of abdominal distension in children? Not about the gas, forget about gas and things like that. What are the three major causes of abdominal distension in children?
Ascites, organomegaly.
The first one is this. What is that?
Organomegaly.
So you can see that this child has got a massive spleen. In fact, this was a patient with Gaucher's disease. Okay, so massive organomegaly is one of the causes. Another cause, as you rightly said, is a child with ascites. This is a child with Wilson disease, decompensated Wilson disease and ascites. What is the third cause? Third significant cause is lump in the abdomen, tumor in the abdomen. It may be due to tumor or neuroblast, whatever that. So these are the three major important causes of abdominal distension in children: massive organomegaly, ascites, as well as a lump in the abdomen. Okay.
Coming to the antenatal and postnatal history, there is no history of fever with rash or lymphadenopathy, no history of contact with pet animals.
What's the importance of all this? A fever with rash.
Fever with rash, if mother it indicates like the mother had significant infections with like torch infections.
Okay, what about contact with pet animals? Is it significant? What is the significance of pet animals? A baby has got cholestatic jaundice and has got contact with pet animals.
Toxoplasmosis may occur in mother if they are exposed to cat.
Okay. Okay.
There's no history of jaundice in mother during the antenatal period. The baby was a full term normal vaginal delivery.
No. What is the most common cause of jaundice in a mother? The most common cause. If you are supposed to only one cause, what would you say? The most common cause of jaundice in mothers is always hepatitis, various types of hepatitis. HELLP syndrome, all these are intrahepatic, these are very rare conditions. If you are asked what is the most common cause of jaundice in the mother, that is again viral hepatitis. Birth weight was?
Birth weight of 3.2 kg.
What's your comment? Birth weight was 3.2 kg.
It indicates that the birth weight was normal. So there was.
What's the average birth weight of Indian babies?
3 kg.
2.9 to 3 kg. So this baby had 3.8. What's important? What is the relevance here?
Like some babies may have small intrauterine growth restriction if they have.
Yeah, so that's the point against intrauterine infection. Okay, that's the point against intrauterine infection, because most of the intrauterine infection, the birth weight will be decreased. So this may be seen in babies with biliary atresia. Babies with biliary atresia tend to look so deceptively fine initially. At least initially they look very healthy with a very good birth weight. So what is the neonatal cholestasis syndrome with large birth weight?
Agnes syndrome. Yes.
Agnes syndrome, absolutely. That's a brilliant answer. Agnes syndrome, children with Agnes. What's the other name of Agnes syndrome?
Norwegian
cholestasis.
Norwegian cholestasis. Okay. What are the classic description stools of biliary atresia?
Clay colored stools.
Clay colors. Okay. What is clay? What is the color of clay? This is the color of clay. Whether you are in Coimbatore or Palakkad, Kerala, Delhi, Bombay, Madras, this is the color of clay in our country. Is it not correct? In Coimbatore, what's the color of clay? I'm sure you'll be having such pots in your house.
Same.
So what's the relation between this? If the baby is passing such stool, you should be very happy. Okay, but postgraduates always say this baby is passing clay colored stool. This has got biliary atresia. How do you correlate? Is it possible?
Like
yeah, yes.
Chinese clay.
Yeah, actually, what is this? This is the Chinese clay. Okay, so what they are referring to should be the Chinese clay and not our clay. Okay, so that is a Chinese clay, not our clay. Sometimes it may be asked in examination, you may be clean bowled. Okay. What is this? Kriti, what is this?
Sorry, sir, I can't see the slide. I'm still seeing the previous slide.
You can't see that? Meenu, can't you see?
No, sir, the Chinese clay slide is.
Pardon?
It has not changed. It is still the same slide.
Which slide? What is this?
It's not moving, sir.
The slide is not moving, sir.
Not moving. Can you read this?
Yes, sir.
Yes, sir.
Progress.
Your mother gave the history. Now it's moving.
Yes, sir. That's.
Can you see this?
Now it's moving.
Okay, right. Okay. So if the mother gives a history of intrahepatic cholestasis of pregnancy, which cholestatic liver disease is the baby prone to develop?
Progressive familial intrahepatic cholestasis type 3.
Type 3. Okay. What the classic description stools of biliary atresia, that also we have seen. Clay colored stools. Can you see the slide now? Can you see the clay?
Yes,
yes.
This is the Chinese clay. Can you see that?
Yes.
Yes.
Okay. Now what is this? Can you see this? Can you see this?
Yes, sir.
This is yellow.
Deep
What is that?
yellowish stools.
What is this? You have been working in newborn ward for a very long time.
Deeply stained yellow color.
Very upset if you don't answer it correctly. What is it? This is only normal stool.
Normal stools.
Normal stools. See, golden yellow stools of normal babies. So this is the typical pale or clay color stools. So you can see the difference. The other one is the first one is the golden yellow stool. The other one is the pale or clay color stool of cholestasis. The stool of a baby with biliary atresia is usually not oily. I'm sure you have seen babies with biliary, so several babies with biliary atresia. Theoretically, we say that they will be passing oily stools, but have you seen oily stools being passed by babies with biliary atresia? No. Why is it?
During the neonatal period, baby is mostly on breast milk, which contains low fat. So
Absolutely, that's a very good answer. Yeah, there are actually milk foods which are relatively poor in fat content. So if such babies are given a lot of fatty food, okay, if a baby is given fatty food, then steatorrhea suddenly become obvious. Okay.
there's no abnormal urine order.
Now, abnormal urine order is a very favorite question of examiners, especially in pediatrics, and you can see that there is a big list in Nelson. So what the relevance of this in neonatal cholestasis?
Tyrosinemia type 1 babies will have abnormal urine order like boiled cabbage.
What is this?
Rancid butter.
Boiled cabbage.
Rancid butter.
So you get two types of urine in type 1 tyrosinemia, that is boiled cabbage urine and rancid butter.
Rancid butter.
So when you're discussing cholestasis, you should be aware of that. Good. Now, what is the special advantage of milk in breast milk in neonatal cholestasis? You know, the milk is the best for milk for breast milk is the best milk for newborn babies. There's absolutely no doubt about it. But it's a special advantage of breast milk in neonatal cholestasis. Anybody?
It's pre-emulsified.
Breast milk fat is pre-emulsified. So it doesn't require emulsification. So it can be digestion absorbed even without the help of bile acids. So what is emulsification? Emulsification is the process when bile enters a small bowel. Bile acids or bile salts will break down large fat molecules into smaller molecules, and this process is called emulsification. So that will greatly increase the surface area of fat. So it's easy for the lipase enzyme to act. Okay. What about cow's milk? It's also natural milk. Breast milk is a natural milk, and hence it is pre-emulsified. Remember that cow's milk is also natural milk. So will it be? Is it pre-emulsified or not? Or what is the difference?
It is pre-emulsified, but it needs to be boiled prior to consumption.
Absolutely right. That's right. That's a very good answer because the cow's milk can be taken only after boiling. When it's once it is boiled, the emulsification will be lost. Okay, Meenu?
There was no setting of blood group incompatibility.
Okay, so already we have discussed this. What is the relevance of this?
If blood group incompatibility is there, then with hemolysis, there may be sludge and this may cause.
What is this condition called?
Inspissated
bile duct syndrome. It's very important to diagnose this condition because sometimes it may clinically exactly mimic or resemble biliary atresia. Okay. What's the simple test to differentiate biliary atresia from inspissated bile duct syndrome?
Ultrasound abdomen.
What will happen in ultrasound?
Inspissated bile duct.
Intrahepatic bile ducts will be normal, so they will be dilated. That's called IHBR, intrahepatic biliary radical dilated. This will not be seen in biliary atresia. Remember that it's not correct to call this condition extrahepatic biliary atresia. It should be ideally be called biliary atresia, simply biliary atresia, because not only the extrahepatic bile duct but also the intrahepatic bile ducts will be affected.
Yes.
Okay, Meenu? Can't you see that?
No, sir. Slide have no history of seizures.
So what are the causes of seizures in neonatal cholestasis?
If the baby have hemorrhage or hypoglycemia in conditions like.
That's right. So intracranial hemorrhage, one of the most serious complications of neonatal cholestasis is intracranial hemorrhage or hypoglycemia due to several conditions like galactosemia, hereditary fructose intolerance. It may be tyrosinemia. Endocrine conditions can also cause hypoglycemia like hypopituitary. So so many causes of seizures in neonatal cholestasis. Have to put examination. Okay.
AF 2 cross 2 centimeter, it was normal, and PF close, no rash, petechy or purpura noted.
How many fontanelles are present in normal baby?
Antefontanelle and posterior fontanelle.
The question is very straightforward. How many fontanelles are present in a normal baby?
4.
In Coimbatore,
5 to 6.
In Coimbatore, Meenu has deleted 2 fontanelles. You are very fond of the anterior and posterior fontanelles, but remember that there are also 2 anterolateral and 2 posterolateral fontanelles. So suppose the examiner asks you how many fontanelles there are at birth, your answer should be 6. Okay. So no rash, petechy, purpura. What's the relevance of dysmorphism?
Dysmorphism. Dysmorphism can be seen in
Just look at this baby. Can you see this baby?
Sir?
Can you describe this baby with cholestasis?
Sir, we don't see the pictures.
Anisha, there is pictures. You can't see the pictures?
No, sir.
No, sir.
We can see it right now.
Sir.
Can you see now?
Yes, sir.
Yes, sir.
Okay. So can you describe the faces? This baby present with cholestasis. What are the classic conditions?
Pointed chin.
Yeah.
Bulbous nose.
Look at the forehead, broad forehead, pointed chin, triangular face, jaundice. Look at the eyes, deep set eyes, a bulbous tip of nose. Okay. This is a classic case of
Alagili syndrome.
this is one of our own patients with Alagili syndrome. Okay.
External genitalia normal.
What's the relevance of cryptorchidism in cholestatic liver disease?
Like if the baby had
Jaundice will be there in Alagili.
there may be cryptorchidism.
Cryptorchidism may be seen SLO syndrome.
Hypopituitary.
Hypopituitary also it may be, genitalia may be small. What the relevance of Billy scrotum? How does Billy scrotum?
Said bile gets within the scrotum. This may occur in spontaneous perforation of the bile.
That's very good. So this condition is due to spontaneous perforation of the bile duct. Okay. So you are answering all the tough questions. Good. What are the conditions which cataract is in cholestasis? How do you correlate cataract and cholestasis?
Congenital rubella syndrome can have cataract, and cataract may be also seen in galactosemia.
Okay. Okay, congenital rubella syndrome. Who described this condition? What is the synonym of congenital rubella syndrome?
Gregg syndrome.
Gregg syndrome. It was discovered by an Australian ophthalmologist called Norman Gregg. It's also known as Gregg's syndrome. Then we have a CMV hepatitis, galactosemia, hereditary fructose intolerance, Zellweger. What is Zellweger syndrome?
Paroxysmal disorder, sir.
What is
Characterized by cerebrohepatorenal involvement.
Which disease does it resemble? These babies look like?
Porphyrias.
These babies, you want a clue?
Yes.
It's not up.
Down syndrome.
Down syndrome.
Then of course, these are some of the associations of cholestasis and cataract. Okay, Meenu?
No microophthalmia. No nystagmus.
Nystagmus. What is the relevance of nystagmus in cholestasis? Suppose a baby with cholestatic liver disease, severe cholestasis developed nystagmus. What may be responsible? Cholestasis. Clue, some deficiency of vitamin. Which vitamin deficiency may cause the cerebellar manifestations, including
Vitamin E.
Vitamin E is correct. That's right. That is vitamin E. Vitamin E deficiency. And sometimes there can be subcongenital hemorrhage. Due to several causes, in cholestasis, there can be subcongenital hemorrhage also. Now, what is this? Can you see this? Can you see the photo?
Yes, sir.
What is that?
White hot spot.
White hot spot. That's right. You can see the lower one also. You can see.
Yes, sir.
So this baby did not have white hot spots or xerosis. Okay, fine. Now, what are the causes of white hot spots in cholestatic jaundice?
Because of vitamin A deficiency, as the fat soluble vitamins are not absorbed in cholestatic jaundice.
Why? Why do they develop vitamin A deficiency? What is the most important cause? Especially the clue is that the COVID situation. COVID situation, children are more prone to develop it. The vitamin D. I'm sorry, not. I was thinking of vitamin D. White hot spot is due to vitamin D. Yeah, the decompensable chronic liver disease. What happens? Retinol binding protein and defective 25 oxidation by the damaged. These are some of the causes. Now, what is the importance of fundus examination in neonatal cholestasis? Have you seen the fundus of this child? You know, have you got an ophthalmoscope?
Yes, sir.
Of your own, not BSc.
Sir?
Have you bought an ophthalmoscope of your own?
Yes, sir. Yes, sir.
You got, very good. For the first time I'm seeing a postgraduate with ophthalmology, because most of my students do not. The importance is that if you're seeing thousands of normal fungi, can you pick up an abnormal fundus? Okay. Only if you're seeing thousands of normal fungi, can you pick up an abnormal fundus? So what's the importance of fundus examination in neonatal cholestasis? What are you trying to?
We can see if any chorioretinitis is seen, like in CMV and in the cataract, and also cherry red spots can be seen, gouges and name.
What is this? Can you see the photograph?
No, sir.
Not yet.
Can't see the photo?
No, sir.
No, sir.
Yes, sir.
I think I got all
Yes,
the
sir.
photos.
That the
Or not?
images come, sir.
Yes, sir.
Okay, maybe it takes some time. So what is this? Fundus?
Sorry.
Retinitis pigmentosa.
That's right. That is retinitis pigmentosa. Maybe it's in Zellweger syndrome. This Zellweger syndrome, you may get retinitis pigmentosa. Cherry red spots are seen in cholestasis. Niemann-Pick C. Remember that it's Niemann-Pick C which causes neonatal cholestasis. Now, what is this and what the relevance in cholestasis? Can you see the photograph here?
Yes, sir.
Okay, what is it?
Lymphedema.
What type of edema is it?
Non-fitting.
Non-fitting type of.
What the relevance of non-pitting edema in cholestasis?
Happens in.
Pardon, already had mentioned that.
Acne syndrome.
Acne syndrome, sir.
Acne
Acne syndrome. So this is actually lymphedema, which may be seen in Acne syndrome. Okay, which is also known as Norwegian cholestasis. Sometimes you may get a question on Acne syndrome. It's an idiopathic familial intrahepatic cholestasis with lymphedema. It's also known as Norwegian cholestasis, not a recessive disease. Remember that this has got a relatively good prognosis because it causes episodic cholestasis.
Yes.
And one of the syndromes with a relatively good prognosis is Agnew syndrome, because the cholestasis is usually episodic. Good prognosis. Okay, Meenu?
Vitals, heart rate 100 per minute, regular in rhythm, respiratory rate 30 per minute, temperature normal, weight of the
What
baby.
may be the cause of bradycardia in a child with liver disease?
The bile salt, which is
In cholestatic liver disease, bile salts may be deposited in the old theory, SA node that may suppress the SA node, resulting in relative brady. What is the other cause in an older child?
If the baby is on beta blockers for
that's a very good answer. Again, that's a very good answer. The child may be on a propranolol or beta blockers for prophylaxis for upper GA grade. Okay.
GA grade.
Weight is 5 kg. That means he is gaining weight.
Gaining weight, well thriving.
It's a thriving child. That's the point in favor of which condition?
It's like against neonatal hepatitis with
maybe a point in favor of biliary atresia. Okay, no dilated, yeah. Okay.
Liver palpable 2 cm below the right costal margin, soft, smooth, sharp borders, and it was non-tender. Spleen palpable 2 cm along the long axis, soft and smooth, and no other mass palpable in the abdomen.
What's the importance of this statement? Remember that in neonatal hepatitis, you get early hepatosplenomegaly.
Yes, sir.
And biliary atresia, it may be
late.
And there's no ascites also. Okay.
No ascites.
Other systems are essential with the normal limits. Now, what are the findings? Can you see the photograph here?
Yes, sir. Yes.
What are the findings in this child? Look at this child.
Grossly
abdominal distension. What else is there?
Dilated veins.
A large number of dilated anti-abdominal veins. What else?
And the scar.
And transverse scar.
What could be the scar due to?
Because post-Kasai could be post-Kasai procedure.
What is this? This is an umbilical hernia.
Umbilical hernia.
This is a child with the biliary atresia who had undergone Kasai's operation. Unfortunately, he has decompensated. He has developed cirrhosis with portal hypertension in spite of Kasai. This is actually a failed Kasai. So what is the significance of dilated anti-abdominal veins? What is the significance when you see a baby with dilated anti-abdominal veins? What is the significance?
It's like in portal hypertension.
Which type of portal? It is extrahepatic or intrahepatic?
Extrahepatic portal obstruction, which causes portal hypertension, and they may
so
have.
At the Meenu Preeti of PSG Medical College in extrahepatic portal hypertension, you will get you will get it. This is a very commonly made mistake proposition. And I'll try to explain that. Okay, so please listen very carefully. It's actually intrahepatic. Why is it that you get dilated anti-abdominal veins only in intrahepatic pattern? Just look at this. This is another child. What are the findings here? Again, you can see the scar.
Down distended transverse scar, umbilical hernia.
Dilated veins. And so another child with post-Kasai. You know that Kijaga was destined to be killed by whom? Kijaga in Mahabharata, Kijaga was destined to be killed by whom? You heard of Kijaga? My goodness, you not heard of Kijaga, Mahabharata, you know, never read Mahabharata, Kriti, Madhumita, Minupi, you never read Mahabharata. Who killed Kijaga? Srinivasan sir should be very unhappy with your answer. You are answering all the tough questions. Well, Kijaga was destined to be killed by Bhim. Who's Bhim?
Beam is.
Bhim. At least know about the Chota Bhim. Anyhow, so if Kijaga has been killed, that means Bhim is responsible. If Kijaga has been killed, Bhim is responsible. Similarly, if there are dilated anti-abdominal wall veins in a child with portal hypertension, the pathology has to be within the liver. It is intrahepatic portal hypertension and not extrahepatic portal hypertension. Now, why is it so? I try to explain. So this is the Kijaga Vadam Ataka. It's very popular in Kerala. Okay. So let's take a look at the anatomy of the portal vein. You know that, can you see the photograph here?
Yes, sir.
Okay. How is the portal vein formed? By the union of the splenic vein and the supramesenteric vein. So it is two parts, the intrahepatic part, which is small, and the extrahepatic part. The intrahepatic part divides into two branches, the right branch and the left branch. Is it clear?
Yes, sir.
Remember that the umbilical vein actually joins the left branch of the intrahepatic portal vein. I hope it's clear till now.
Yes, sir.
Now, when a child develops cirrhosis with portal hypertension, what will happen? When a child develops cirrhosis with portal hypertension, you can see the sinusoids. All the sinusoids will be blocked because of fibrous tissue. So the pressure within the sinusoids will be increased. The proximal pressure goes on increasing, and that will be transmitted back to the portal vein. Okay, when the distal pressure is increased because of fibrosis, the blood from the portal vein is not able to reach the central vein. So the pressure naturally will be increased in the portal vein, and this will be transmitted back to the big portal vein also. So when there is cirrhosis, there will be increased pressure in the intrahepatic portal vein also. So when the pressure within the intrahepatic portal vein increases, what will happen? Blood will start flowing through the umbilical vein, because the umbilical vein is joining the left branch of the portal vein. So in cirrhosis, what happens is that the blood starts flowing through the probe patent umbilical vein. And where does it reach? It reaches the periumbilical area, and there are a lot of collaterals there. That is the reason why you get dilated anti-abdominal veins. You get it only in intrahepatic portal. That is cirrhosis with portal hypertension. It is clear to you?
Yes, sir.
Okay. Yes, sir. So sinusoidal pressure increases in cirrhosis. Okay. So consequently, the portal vein pressure increases, and the blood starts flowing through the umbilical vein to the para-umbilical vein. And there will be dilated anti-abdominal veins, which are flowing in from the umbilicus. So if there are dilated anti-abdominal veins, the pathology is within the liver. It is intrahepatic portal hypertension, it's not extrahepatic portal hypertension. Let's see a child with extrahepatic portal hypertension. So this is intrahepatic. Can you see the photograph here, right side? Can you see that?
Yes, sir.
Okay. So you can see that the extrahepatic portal vein is obstructed. So what will happen to the blood flowing from the splenic vein, and the blood flow is actually decreased. So the liver actually doesn't get blood flow at all. And hence there is no question of the pressure within the liver increasing in extrahepatic portal hypertension. Is it clear to you?
Yes,
so the
sir.
blood now cannot flow through the umbilical vein. And hence there cannot be dilated anti-abdominal veins in extrahepatic portal. I hope it is clear to you now.
Yes, sir.
Okay, fine. Thank you. Now, another common finding, common question asked in examination is, you know that there is a disproportionate enlargement of the left lobe of liver in cirrhosis. You know that? When you examine a child with cirrhosis, for a post-hepatic cirrhosis or Wilson disease with cirrhosis, the right lobe will be shrunken and the left lobe will be disproportionately enlarged. Why is it so?
The flow of blood will be towards
Flow? If we are not very sure, I shall explain. You want me to explain?
Yes, sir.
Okay. See, you know that the superior mesenteric vein normally carries nutrients from the gut, and the blood from the superior mesenteric vein is supplied mainly to the right lobe. It's clear. So blood from the superior mesenteric vein is supplied mainly to the right lobe. Now, what about the splenic vein? The splenic vein carries hepatotrophic factors from the pancreas, because the splenic vein is joined by the pancreatic veins. So from the pancreas, the hepatotrophic factors reach the splenic vein. Okay, and normally this splenic vein supplies both lobes, right lobe and left lobe, equally. So superior mesenteric vein normally supplies only the right lobe, whereas the splenic vein supplies both lobes equally. So both right lobe and left lobe will get hepatotrophic factors. Is it clear to you?
Yes, sir.
Now, what happens in cirrhosis is that there is a redistribution of blood flow because the hepatic artery is distorted by the fibrosis. So the blood supply to the liver is altered because of hepatic fibrosis. So consequently, what happens is that blood from the splenic vein with its hepatotrophic factors is preferentially supplied only to the left lobe. Okay, so only the left lobe now gets blood from the splenic vein with its hepatotrophic factors, and hence the left lobe hypertrophies. It hypertrophies because it gets a lot of hepatotrophic factors, while the right lobe atrophies because it doesn't get these hepatotrophic factors. Is it clear to you?
Yes, sir.
Okay. Hope it is clear to you. If it's clear to you, we'll go to the next slide. No, congenital heart disease and cholestasis are seen in which conditions? Congenital heart disease.
Congenital rubella syndrome.
Congenital. What are the cardiac lesions of congenital rubella syndrome? The most common one. Very simple. PD is the most common condition of patent ductus arteries. Second one is
Peripheral pulmonary stenosis.
Peripheral pulmonary stenosis. Okay. Second one is Alagille syndrome. What is common to Alagille syndrome and congenital rubella syndrome as far as congenital heart disease is concerned?
Both have
Peripheral pulmonary stenosis.
Very good. Both have got peripheral pulmonary stenosis. Then we have other rare conditions like Smith-Lemli-Opitz syndrome, syndromic type of biliary disease. Okay. So these are the associations of congenital heart disease and cholestasis. Okay. Now summary. Now summarizing a case is an art that has to be perfect. I'm sure you know that it is an art which has to be perfected. Usually in the examination start when you're asked to summarize, you'll go on saying this child born to consanguineous parents, history is given by the grandfather, grandmother, it is not reliable, she's coming from Coimbatore. No, it has to be very short. So it is often compared to a European lady's micro mini skirt. So it should be very short, it should be exciting, and should reveal everything. In a few sentences, you should reveal everything. That's the importance of summarizing a case. So this is an art which postgraduates like you should perfect. So what is the summary and diagnosis? You know?
This is a 90-day-old female child born to non-consanguineous parents. It is a term appropriate for gestational age baby with birth weight of 3.2 kg present with jaundice, high-colored urine, and persistent pale-colored stools from first week onwards. There was no dysmorphism, pale type, ascites, coagulopathy, or encephalopathy.
Okay, so it's very easy now. Okay, so it's only minimal or
haptosplenomegaly beyond examination.
Okay, so this
neonatal cholestasis most probably biliary atresia.
So this child has got a neonatal cholestasis. Most probably this is biliary atresia. Now, what are the points in favor of biliary atresia?
So this baby had a appropriate gestational age.
Gender. Okay, start with the gender.
Gender.
Okay. Then non-consanguinate. If it were born to consanguinous, then I can think of the genetic conditions. Then good birth weight. Initial thriving this child.
Health thriving.
Markedly pale stones. That's another classic presentation. In the other conditions, in intrahepatic infection, you get an intermittent pale stools. Here you get a persistent pale stools. Then it is into microcephaly, it is into congenital heart disease, it is into cataract. Splenomegaly is only very small. So because of these features, we feel that this child could be having biliary atresia. But remember that it will be sometimes extremely difficult to differentiate biliary atresia from the other cause of cholestasis. It's very easy to say that because of these reasons, this child is having biliary atresia, but the diagnosis may sometimes be different. And remember that it doesn't run in families.
There's not an
The other condition, there may be some family history. So because of these reasons, we feel that this child could be having biliary atresia. Now, what is physiological cholestasis? But this is seen in preterm babies. You know that there are several transport proteins. Sometimes you make a short note on transport proteins like NTCP, bile salt export pump, etc. So in preterm babies, the expression of these transport proteins may be minimal. So these transport proteins may not be complete or well expressed. And so because of this, there can be some amount of cholestasis which will subside of its own. So this is called physiological. So cholestasis can sometimes be physiological also. Need not always be pathology. Okay. What is transient cholestasis? Can it be transient?
Sir, like
Perinatal disease causing fetal congestive cardiac. Suppose there is a congestive cardiac failure. Fetal arrhythmias. Which condition can cause fetal heart block?
neonatal lupus.
Neonatal lupus, congenital heart block. So blood supply to the liver may be decreased. That can be cholestasis. So if you start steroid, what will happen? The cholestasis will resolve. Cholestasis is resolved with steroids. Okay. Or a condition like congenital hyperthyroidism, that can be cholestasis, and which with replacement therapy with thyroxine, cholestasis. So this is called transient cholestasis. Now this child, look at this child. Can you see this photograph?
Yes, sir.
Yes, sir.
So this child was referred to me with a diagnosis of Corey biliary atresia, but it's actually not biliary atresia. What are the features in this child? Look at this child.
Post facial features. Umbilical hernia.
You can see that he's got an umbilical hernia. He's got macroglossia, abdomen distension, macroglossia. And so this was actually a simple case of congenital hypothyroidism. His jaundice subsided. This is the classic case of congenital hypothyroidism. He became all right with L-toxin replacement therapy. So that is transient cholestasis. On the other hand, just look at this child. This is biliary atresia. Another child with biliary atresia. Again, you can see the large number. Can you see the veins here? What is this?
Yes, sir.
What is this? This is an incisional hernia. Okay, this is an incisional hernia. That's an incisional hernia. Okay. Now, as a pediatrician, as a resident of pediatrics, your idea is to make a basic distinction between extrahepatic disorders, because they may require early surgery, from intrahepatic disorders which do not require surgery. So you should be tuned to differentiate extrahepatic disorder, cholestasis, from intrahepatic disorders which do not require surgery. You should always roll out treatable causes like transient cholestasis, septicemia can cause cholestasis, inborn erythroid metabolism. Never forget endocrinopathies. When a child has got persistent hypoglycemia, it may be secondary to hypopituitarism. So you don't consider the possibility of a hypopituitarism. Remember that you got a child with a cholestasis who is not responding to any sort of treatment. You can't come to a diagnosis. Think of the possibility of hypopituitarism also. So we should make a distinction between extrahepatic disease, which requires surgery, from intrahepatic disease. Can you see the slides?
Yes,
Yes,
sir.
sir.
Now, what is the most important clue to the diagnosis of neonatal cholestasis? Just like this famous Alfred Hitchcock thriller, Suspicion, starring Cary Grant and John Fontaine. Suspicion is very important. You should not feel, oh, this is going to be biliary. This may not be sometimes biliary. So you should always, as pediatrics, as residents of pediatrics, always think of the other. You should always be a suspicious person. Okay. So how do you approach a child with neonate with cholestasis? What the first step? First step is history taking. What is the second step? Kriti?
Examination.
Second step is also history taking. The third step is also history taking. I've written history taking 3 times. Not that you should write in your answer paper 3 times history taken. If you do not take a proper history, I'm sure that you will miss the diagnosis. So you take a proper history, then you examine the child and do relevant investigation. So pediatrician should be like whom?
Sherlock.
You should always be like Sherlock. Not only when evaluating neonatal cholestasis, any disorder, we should be inquisitive like Sherlock Holmes. So there are 2 questions to be asked to the jaundice patient. What is the first question? Suppose the child is coming to you with jaundice. What is the first question to be asked? The first question to be asked is, what is the color of the urine? Okay. Suppose the mother says the urine is a normal color like this. That means this child has got an unconjugated jaundice. So you do the investigation. Already we have done, you have present an excellent case on unconjugated jaundice. It may be hemolytic jaundice, a newborn period, we already discussed. So hemolytic workup may be significant. Suppose the mother says the urine is high colored. So like this. So what is the possibility? This is a conjugated jaundice. What are the causes of conjugated jaundice? It may be due to hepatitis or maybe due to cholestasis. So we ask the second question to differentiate these. What is the color of the stool? Okay. Suppose the mother says it is normal colored stool. That means probably this is a medical cause, hepatitis jaundice. So do the investigations for hepatitis, drugs, metabolic liver disease, Wilson disease, etc., etc. Okay. Is it clear? But suppose the mother says it is pale like this. Can you see the pale stool here?
Yes.
Yeah. If the stool is pale, then that means he has got a cholestatic jaundice. Cholestatic jaundice. So you do the investigations for a cholestasis like ultrasonography, CT, ERCP, etc. With this, it should be possible for it to come to a reasonably good diagnosis. But remember that you should always believe the mother who is worried. If the mother is worried, there is something wrong with the mother's. If you got a baby whose mother is very much worried, that should always be taken seriously because she is likely to be correct. Now we'll have some revision questions. Are you ready?
Yes, sir.
Most of the answers you should be knowing by now, but there may be some questions of which you may not be knowing. You can write your answers if possible in the chat box, or you can answer also. Okay, Srinivasan sir. So name the countries with the highest incidence of biliary atresia.
Japan and Thailand.
First country,
Taiwan.
Taiwan, and Taiwan is at 3.7 per 10,000. Japan comes next, 1 point. European countries is only 1 in 12,000 to 18,000. So the country with the highest incidence of biliary atresia in the world is Taiwan, 3.7 per 10,000. When you suspect neonatal cholestasis, when the baby has got high-colored urine, staining of diapers, and pale stools, and of course pale stools. Okay, persistent or intermittent pale stools after passing meconium. Is there a screening for biliary atresia? Is it possible to screen for biliary atresia? Yes. The presence of conjugated jaundice, that's the most important screening test. If a baby has got conjugated jaundice, there's always abnormal. You have to rule out biliary atresia or some other cause for cholestasis. Then, of course, we have the stool card, which is very popular. It was introduced from which country? Taiwan. Have you seen it? Have you seen it?
Yes.
5, 6.
Yes, I'll show you that. So name the, this is the universal screening chart. Is there a screen? Oh, yeah. This is the universal screening for biliary atresia using infant stool card introduced from Taiwan. You can see that the top 3 are the abnormal urine colors. These are the normal stool colors. So all the mothers in Taiwan will be given this card. And if the mother feels that the baby's stool corresponds to the first 3, upper 3, the child should be immediately brought back to the pediatrician. And they have picked up a lot of babies with biliary atresia with this. Name the neonatal cholestasis with the high alpha fetoprotein levels, very high alpha fetoprotein levels.
Tyrosinemia, sir. Type 1.
Always a type 1 tyrosinemia. Don't see this tyrosinemia, this type 1 tyrosinemia. Citrin deficiency is a very important topic for you. Please study more about citrin deficiency. The neonatal hemochromatosis. What is the current name for neonatal hemochromatosis? That's called gestational alloimmune liver disease. Gestational alloimmune liver disease. These are the conditions with very high levels of alpha fetoprotein. Name the cholestasis syndrome with a relatively good prognosis. One is Agnes syndrome. It's also known as Norwegian cholestasis. Another one is citrin deficiency. Citrin deficiency too has got a relatively good prognosis. Remember that citrin deficiency is common in Asian babies. It's more common in Asian babies compared to Caucasian babies. So it's of great importance for Indians also. So these are the 2 syndromes with relatively good prognosis. Another one is BRIC. I'm sure you know about BRIC is the benign recurrent intrahepatic cholestasis. It's also known as the summer skin. Then remember the inborn errors of bile acid synthesis. There are a lot of conditions, the inborn errors of bile acids, and most of these conditions have got a relatively good prognosis. Sometimes we get a short note on these conditions. Name the neonatal cholestasis with fulminant hepatic failure right from birth, day 1.
Herpes.
One is
Herpes.
GALD. One is GALD, gestational alloimmune liver disease. Second, that is also known, the old name is neonatal. Second one is type 1 tyrosinemia. Then HLH, don't forget about HLH. HLH is another very important topic for you, not only in gastroenterology, but hematology, neonatology. Study more about HLH. What should a pediatrician do as soon as he sees a baby with skin? Suppose you are all about to pass your MD pediatrics with flying colors, and suppose you are practicing the periphery of Tamil Nadu. At 1 a.m., you get a call, and there's a baby with cholestasis. What will you do?
You have to give injection vitamin K.
That's an excellent answer. One of my students said, I will do an ultrasonography. Is it possible to do ultrasonography at 1 a.m. in a remote area of Tamil Nadu? It's not necessary also. But remember that these babies are highly likely to be deficient in vitamin K. So they are found to develop intracranial hemorrhage. So as a pediatrician, it's your duty to give just a shot of vitamin K. Which antibody should be avoided in cholestasis?
Ceftriaxone.
Ceftriaxone, that's all. Ceftriaxone. Due to several reasons, ceftriaxone is better to avoid. Neonatal cholestasis with large birth weight.
Agnes.
Syndrome. Very good. Agnes syndrome. The absorption of which fat soluble vitamin is poorest in cholestasis?
Vitamin D.
Vitamin D. We are fond of the sunshine vitamin. It's actually vitamin E. Very difficult to absorb vitamin E without bile acids. So what will you do? How will you prevent vitamin deficiency in chronic cholestasis?
We have to supplement vitamin E.
You can give large doses. You can give up to 1,000 international units per day. You can give large dose of vitamin E. Or what is the latest drug? Anybody? What is TPEC 1000? Heard of that? Vitamin E is bound to alpha tocopherol. That is alpha tocopherol bound to polyethylene glycol succinate 1000. So this is called TPEC 1000. This molecule is available in the Western countries. Unfortunately, it is still not available in our country. If it is available, this will be very easily absorbed. In spite of cholestasis, this can be absorbed. Okay. Can I go to the next slide?
Yes, sir.
Yes, sir.
What the treatment for severe pruritus? What the treatment of severe pruritus? You can try bile acid jaundice like cholestyramine, cholesterol. Latest one is cholesterol hydrochloride. This is the latest drug. Very potent drug, cholesterol hydrochloride. Then we have the drugs like we make a short note on ursodeoxycholic acid. What is ursodeoxycholic acid? It's a tertiary bile acid. Dose is 10 to 50 milligram per kilogram. People have tried the time test of phenobarbital. Opioid antagonists have been tried, naloxone, naltrexone. Rifampicin has been tried. So many drugs have been tried. So these are some of the drugs which have been tried in the intractable pruritus of cholestasis. What is the surgery for intractable pruritus of PFIC? What is PFIC? The very important topic for this. It's a huge topic. Please read up more about the PFIC. Or the surgery for intractable pruritus of PFIC, which is not responding to any treatment, any medical treatment. Bile diversion, that's right. It's going to do biliary diversion procedures. These are available now. And the aim is to interrupt the enterohepatic circulation of bile acids. So biliary diversion procedures and a nasobiliary drainage too has been tried. You can pass a catheter through the nose into the bile duct and drain the bile. So these are some of the surgical techniques for intractable pruritus of PFIC. Okay. What's the mechanism of a low GGT in PFIC 1 and 2? Heard of that? PFIC 1 and 2, what is the mechanism of low? You know that in PFIC 1 and 2, in some PFICs, GGT is low. You know that? Heard of that? One of the best tests are screening tests for cholestatic liver disease is to look for GGT, because there are several conditions there, low GGT, especially in PFIC, and some of them are PFIC 1 and 2. So it's not given in Nelson. So you know that GGT is normally secreted by the biliary canalicular cells. Can you see the biliary canalicular? Can you see the photograph? Can you see biliary canalicular cells? So in PFIC 1 and 2, what happens? And the stimulus for secretion of GGT is the presence of bile acids in the biliary canaliculi. Is that clear? So bile acids should reach the biliary canaliculi to secrete GGT. And PFIC 1 and 2 are such conditions. The bile acids cannot reach the biliary canaliculi. So they cannot stimulate the biliary canalicular cells to secrete GGT. Is it clear?
Yes.
The tricky situation. On the other hand, in PFIC3, GGT is normal because the bile acids can reach the biliary canaliculi in PFIC3. So it may be asked an examination. What is the role of GGT? Why it is decreased in some conditions? Why it is increased in some conditions? Which disease is peculiar to pregnancy may lead to neonatal cholestasis? I had already mentioned that. Intrahepatic cholestasis of intrahepatic cholestasis. PFIC3. What is the importance of urine order in neonatal cholestasis? You already discussed. Urine. Name the drug used in tyrosinemia type 1. Or the drug of choice. It almost right. Is nitisinone. A very good answer. That is nitisinone. Nitisinone is the drug which has been tried in type 1 tyrosinemia. Which metabolite is responsible for liver damage in type 1 tyrosinemia? Pardon? I think I had already shown that by accident. That is succinyl acetone. It's a succinyl acetone. Again, type 1 tyrosinemia is a very important topic for you. So this is the metabolism of tyrosine. What is the enzyme deficient in type 1 tyrosinemia?
Fumarate acetoacetate hydrolase.
Again, that's a very good answer. You can see that fumarate acetoacetate hydrolase, this enzyme is deficient, so that fumarate acetoacetate will accumulate, and that is converted to succinyl acetone. What's the importance of succinyl acetone? This can affect the porphyrin pathway, and the baby with type 1 tyrosinemia may present with features suggestive of porphyria. Okay, because it can inhibit, succinyl acetone can inhibit porphyrin metabolism. Which cholestatic disease presents the painful crisis resembling porphyria? I just mentioned type 1 tyrosinemia, type 1 because succinyl acetone can inhibit the porphyrin metabolism. How will you diagnose it?
Urinary or serum
Name the cholestatic disease which purity is absent. One is inborn bile acid metabolism because bile acids are not synthesized. What are the cause of relative bradycardia? Again, you are
Deposition of bile salts.
The old theory or propanol therapy for portal hypertension. Which PFIC has the worst prognosis? Type 2, correct, absolutely right. Type 2, PFIC2 has the worst prognosis because it can cause cirrhosis, hepatocellular carcinoma, and all sorts of complications. In which cholestatic disease is liver transplantation contraindicated? Zellweger syndrome. What is? Some more. Zellweger syndrome is a multi-system disease. There is no point in doing liver transplantation alone. It's a multi-system disease. Then we have HLH, and Smith-Lemli-Opitz. I'm sure that you will get questions on Smith-Lemli-Opitz syndrome also in pediatrics, MD or in DNB. Okay, the Smith-Lemli-Opitz syndrome is a very important topic for you. What are the indications for liver transplantation in biliary atresia?
Failed Kasai.
That's right. Failed Kasai.
End-stage
liver. Or failed Kasai was an excellent answer. Failed Kasai. End-stage liver, again, you have answered in that particular order. Progressive cholestasis, intractable ascites, recurrent uncontrolled GI bleed due to portal hypertension, intractable ascites, severe coagulopathy. These are some of the indications for doing liver transplantation in biliary atresia. Okay. And a rare complication called hepatopulmonary syndrome. There is no other treatment. The only treatment option for hepatopulmonary syndrome is liver transplantation. What's the importance of fundus examination? Again, we have discussed that. What is this?
Retinitis
pigmentosa. What is the other one? That is stereotypical Niemann-Pick C. Okay. What's the importance again? What is this? What is this? Both are the same. What is the striking abnormality of this one? As again I mentioned, only if you have seen thousands of normal fundi can you visualize, pick up an abnormal fundus. But I know I'm very happy that the PGs of PhD have got, all of them have got ophthalmoscopes of their own and not provided by the PhD, because you can't take the ophthalmoscope given by the PhD when you pass your exam. Now, what is the finding here? Kriti?
Atrophy.
Yes, you're right.
Atrophy.
Yeah, that is optic atrophy. You can see the chalky white disc. This is optic atrophy. What the correlation? Neonatal cholestasis and optic atrophy is condition called demorphic syndrome.
Septo-optic dysplasia.
Septo-optic dysplasia. Demorphic syndrome is also known as demorphic syndrome or the septo-optic dysplasia. Okay, what the relevance of this bird in neonatal cholestasis?
How the inclusion bodies in cytomegalovirus?
Yeah, so you can see the all-out inclusions in the urine of a patient with cytomegalovirus hepatitis. Can you see that? Can you see the photograph on the right side also?
Yes.
Can you see that? Okay. The typical all-out inclusions of hepatitis. Now, what is this? This is the liver biopsy finding of a child with cholestatic liver disease. This is one of the classic liver biopsy findings in periodic hepatology, which examiners are very fond of. What the finding? What the diagnosis? You want a clue? Examiner asks you whether you want a clue or not. Always say yes. Gene is on the long arm of the 14th chromosome. Gene is on the long arm of the 14th chromosome.
Alpha-1 antitrypsin deficiency.
Absolutely right. Who said that? So can you describe it? What the liver biopsy finding of alpha-1 antitrypsin deficiency?
Magenta-colored inclusion bodies are seen in the
endoplasmic reticulum.
Magenta-colored globular inclusion within the cisterna of the endoplasmic reticulum of periportal hepatitis. I'm afraid you like to by heart this. Some of the very favorite question. I am very fond of it anyhow. Okay. That is alpha. I think you are very good students. So you have answered most of the tough questions. Except Bhima, who killed. You didn't know who killed Kijaga. Okay. What are the cardiovascularization lesions of Alagille syndrome? But the most common is peripheral pulmonary stenosis. So it got some resemblance to congenital rubella syndrome. Second one, what are the other lesions?
TOF, AST, BST.
Don't say TOF because I know one TOF is the fistula is also TOF. So always the tetralogy of the peripheral pulmonary stenosis, tetralogy fellow,
AST.
You get pulmonary artery, VST, AST, etc. The most important ones are peripheral pulmonary stenosis and tetralogy fellow. You can even get a coarctation of aorta. Now, you know that it's very difficult in Calicut or Kerala to treat children of teachers, nurses, and doctors. Very difficult to treat children of teachers, nurses, and doctors. Okay. There will be a teacher, especially so teachers. So this is the only child of our child after 15 years of marriage. Only child after 15 years marriage, and unfortunately, both were teachers. And he had a cholestatic jaundice. What are the findings? What are the findings here? Look at the. Can you see the X-ray?
Yes, sir.
Yeah. What are the findings in the X-ray?
Dextrocardia, sir.
Only dextrocardia.
Situs inversus.
So this child has got dextrocardia with situs inversus. This ultrasound shows small spleen on the right side, liver is on the left side. Okay, this is the isotope study. This is a mebrofinin scan. You can see that the isotope is trapped within the liver. It's not coming out into the gut. Instead, it comes back to the bloodstream and it is excreted in the kidney and is reaching the urinary blood, which shows that this is likely to be, can't say sure, but this is likely to be biliary atresia. So you can see that laparotomy has been done. What's the finding here? Absolutely no extrahepatic bleed apparatus, and the liver is cirrhotic. Liver is already cirrhotic. And what is the surgery? This is the Kasai's operation.
Kasai precision.
So our pediatric surgeon did a Kasai's operation, but the already liver is cirrhotic. So very late. So this is what happened to the patient. This is the patient with, I think you already seen this photograph. Intractable ascites, large number of dilate anti-abdominal vein. So where is the portal hypertension? Extrahepatic or intrahepatic?
Intrahepatic.
This is intrahepatic. Okay. You can see the umbilical hernia, you can see the incision hernia. Lots of findings here. Unfortunately, this child also subsequently died. So it's why is it important to accurately localize the apex between biliary atresia? The same reason. Sometimes there can be dextrocardia and there may be situs inversus, as happened with our patient. What precautions should we take when we send a baby with suspected biliary atresia for ultrasonography? 3 hour fast. at least a 3-hour fast is important. Otherwise, it may not be possible to visualize the gallbladder. So make sure, even if the baby is crying, to make sure that the baby is not taking milk feeds. You may give water, you may give, but you don't give breast milk because the gallbladder will come down. It will be very difficult to visualize the gallbladder. Then subsequently, if the gallbladder is imaged, then you can ask the mother to feed the baby to demonstrate whether the gallbladder is functioning or not. Recently, name 2 recently discovered USG findings in biliary atresia.
Triangular cord sign.
Triangular cord sign and
Ghost gallbladder.
pardon?
Ghost gallbladder.
Gallbladder ghost child. So we have the triangular cord sign and the gallbladder ghost. So what is triangular cord sign? So this is the triangular cord sign. Linear cord of echogenicity along the portal. This is the triangular cord sign. It's actually not much of a triangle. Anyway, that is the triangular cord sign, which can be picked up by an experienced radiologist. Now, what is this?
Ghost
It's the normal gallbladder. In biliary atresia, it is attractive. It looks like a ghost of the normal gallbladder. The gallbladder will be very strong. The contour is irregular, and the wall is very indistinct. Very indistinct. So this is the triad of the gallbladder. The gallbladder looks like a ghost of the healthy gallbladder. That's the reason why it's called gallbladder ghost triad. But the typical triad of cold occult cysts.
Jaundice, abdomen pain, and mass in the right side.
Jaundice, right hypochondriacism.
But remember that may not be seen in all patients. May be seen only about 20 to 30% of patients. But this is the classic triad of cold occult cysts. What is the antiviral therapy for same-way hepatitis?
Gancyclovir.
Controversial. It's actually controversial because it's very expensive. The toxic drug, scanty data inside, but there are some definite indications. What are the definite indications for antiviral therapy in same-way hepatitis? One is CMV retinitis. Second one is encephalitis. Third one is pneumonitis. So if the baby has got these features, that is a definite indication for starting. Otherwise, it's a controversial issue. It's a toxic drug and it will be given expensive. It has to be given for a very long time. What is specific treatment in neonatal hepatitis? Which neonatal hepatitis has got a specific treatment? Galactosemia. Galactosemia. Specific treatment. Hereditary factors and specific treatment, dietary therapy. Tyrosinemia, there's a drug available. Only thing is extremely expensive. And of course, for CMV hepatitis. These are the drugs used in treatment of CMV hepatitis, but it's a controversial issue. But sometimes it may be asked an example. What are the cholestatic syndromes? Definite or specific treatment. These are some of the cholestatic diseases with a specific treatment is available. Toxoplasmosis, the treatment is with spirometry. GALT, IVIG. GALT is a very important topic for it. Please look up more, study more about GALT. Who is this? Is it Kawasaki? Is it Kawasaki?
No.
Where do you think this person is?
It's not Kawasaki.
Pardon?
It's not.
It's not.
Is he an Indian? Do you think he's an Indian? Does he look like an Indian? No. We are discussing biliary atresia. So, yes, Kasai is Kasai. Is the Morio Kasai who described the Kasai as hepatoporta and prostable. So this is Morio Kasai. It was described way back in the 1950s. Okay. So what are the complications of Kasai? Post Kasai, what are the complications? Cholangitis, we already discussed that. Okay. Then it can fibrosis, subsequently there can be cirrhosis, portal hypertension, and long-term cirrhosis can lead to malignancy. These are some of the common. And don't forget about hepatopulmonary syndrome. Sometimes they may ask a short note on hepatopulmonary syndrome. What are the causes of delayed referral of neonatal cholestasis? What are the causes? Why people do not refer cholestasis in time?
Intermittent phase 2, so that the mother might not have noticed and came to the.
That's right. Yes. So these are misdiagnosis as a physiologic jaundice. Improper follow-up of a neonatal jaundice. You should always make sure that the jaundice has subsided. And you ignore the mother's complaint that urine is high. You should never ever ignore the, what happened to our patient? Child was actually taken to a doctor who said that is okay. Okay, so ignore the mother's complaint that the urine is high colored. And soon after birth, there may be physiologic diuresis. So the urine tends to be deceptively diluted. And people are so fond of heliotherapy. And there is a drug called Leaf-58, which is a very popular one. For all cases of jaundice, they used to give, it used to be the panacea of all types of jaundice or liver disease. And heliotherapy, this is heliotherapy. So, rod roller pace, what is rod roller pace of investigation? A pediatrician is not aware of the importance of cholestatic jaundice. What will you do? He adopts the wait and watch policy, tries non-specific drugs like Leaf-52, and refers the child quite late. It will be quite late then. And remember that these babies had to be referred promptly. So this is called the rod roller. You have seen rod rollers, they move very slowly. So this type of evaluation is called a rod roller pace, snail pace or rod roller pace. So on the other hand, thanks to the efforts of IAP, NNF, and pediatricians and pediatric gastroenterologists, people like you are referring these babies promptly now. This is called the fire brigade. You see the fire engine, fire brigade pace. Okay, so as a pediatrician, there's the budding pediatricians, and I would request you to adopt the fire brigade pace and not the rod roller pace. So always refer urgently babies with conjugated jaundice. Okay. Now, how should pediatricians tackle neonatal cholestasis? So please take it in a lighter way. Now, this is not. You should not take it very seriously. Are you ready for that? You're not ready.
Yes, sir.
Yes, sir.
So suppose the baby comes to the pediatrician now. So the pediatrician should be aggressive. So that's so this is the pediatrician, this is the cholestasis. He's doing it aggressively. What about a European pediatrician? European pediatrician is actually more aggressive, like this. Okay. Who are the most aggressive people on earth now? Who are the most aggressive people on earth now? That's the Americans. So how do the American pediatrician tackle it? Extremely aggressive. Okay. You need not exert such severe degree of aggression, but how do we tackle, how we used to tackle in the past? How do we, or how we used to tackle cholestasis? See, we are very happy with heliotherapy, Leaf-52. So we never made a diagnosis because we believe in non-violence. The child with cholestasis is dying of his own. This should never happen. And fortunately, I'm sure that with pediatrician, budding pediatrician like you, this will not happen in India. Okay, then thank you so much. I'm sure that I have enjoyed representing this case, and I would like to congratulate Meenu, Preeti, and all the others, Meenu, Madhumita, Kriti, because their answers have been wonderful. All the tough questions they answered so promptly. But of course, why was I disappointed? Because you didn't know, you're not read Mahabharata, because you didn't answer, you didn't know who killed Kijaga. Who killed Kijaga? Kijaga was destined to be killed by Beam. So if Kijaga has been killed, Beam is responding. Similarly, if a patient with cholestasis, the liver disease has got dilated antiabdominal veins, the pathology is within the liver. It is intrahepatic population. Okay, thank you so much.
Thank you, sir.
What is the verdict? I'm sure Meenu Preeti has passed with MDP.
Can you stop slide sharing, sir?
She's passed with flying colors. Meenu Preeti has passed the examination with flying colors. Please give her a big hand.
Yeah, it's a good exam-oriented preparation. I think it is really useful for the postgraduates. And I think today we are having judges, Dr. Srinivasan, sir.
Srinivasan, sir, has nothing to say. So, Madam is answering some questions, so she can say. Yeah. Suddenly the camp workings have come. I didn't want to show my
nice
face.
to see you, sir. So nice to see you. It's really refreshing to see your face.
Yeah, every time I listen to him, I want to read the gastrointestinal system again, because 80% of the questions I may not be able to answer.
Yes, sir.
Dr. Elilasi, madam. Yeah.
Sir, good evening, and what a wonderful session. So the students and the teachers, I think we should
today the three of the students, they were answering everything, and the teachers were also wonderful. Their questions were so nice. And sir, Riya sir, what a picturesque presentation in a class for all of us. Literally, it was a enjoying session, sir. As you said, everybody should know Mahabharata also. With your questions were awesome, and yeah, the way you made the students so confident. And of course, the physiological jaundice, Dr. Abhiramalata, she also made it very pleasant, very quick. And the mentor of PSG, I think all of them passed, and the teachers, especially with Centum. It was just awesome. Thank you, IAP. I really enjoyed this session.
I want
like
to
a firefighter.
Yeah, I want to make one personal comment. Both arts are always young. You know which arts I am talking about.
Yes.
They look the same for so many years. There is no change at all. That is because I interact with students so much, they remain young.
So same thing I told, sir. I think I was seeing him 15 years back. Same thing he's maintaining. I want to know the secret.
We are always dealing with young children.
Yeah.
Young students.
And students, of course, young students.
Dr. Janani, madam. Dr. Janani, madam. Dr. Janani is there? Yeah. Dr. Janani, madam.
She was there?
Yeah, she's there. Okay.
Maybe.
I don't know. Probably.
Yeah, Dr. Ramesh. Yeah.
It's a really nice to. It's really nice to hear Dr. Riya Sar's presentation or narration about the cholestasis. I remember my DCH days when we were reading Dr. Riya Sar's book on pediatric gastroenterology. Yesterday we were discussing, myself and Dr. Abhiramalata were discussing about how we were very fond of reading that book during our
even now
at ICH. So it's a really nice to hear. It's a long back we moved away from the pediatric gastro. It's a really a wonderful recollection of our memories about the things we read from Dr. Riya Sar's books. Sir, very happy to be a part of this panel, sir. Thank you so much, sir.
Thank you so much, Ramesh. Thank you. I really
yeah, Dr. Janani is there, I think. Dr. Janani, madam.
She's
yes, sir. It was really wonderful presentation by the students of PSG, and I think Riya's, we've always been a fan of Dr. Riya's. It was wonderful, his questions and the way he conducted, and Dr. Abhiramalata was also really good. Thank you for the opportunity.
Thank you, madam. Dr. Abhiramalata.
I think whatever I wanted to say, Ramesh sir already said. We also enjoyed, and I also took notes, sir, of your session. Thanks a lot for teaching us.
Yes.
Thank you so much. I really enjoyed your class, the way you are asking questions. Very nice.
Yeah.
I not
very sweet
about unconjugated jaundice for a very long time because I don't see neonates. Thank you very much.
It's a final conclusion remark, Dr. Yes, sir.
Okay. So it was a very enjoyable session. I'm sure that the postgraduate students of a PSG, they're wonderful. I would like to really congratulate the teachers also. If the students are good, that means the teachers also equally good. I'm sure that they will come out with flying colors not only in the MD examination, they're all going to become super specialists.
Yeah. So, on behalf of IAP TNIC, I thank today's Dr. Chairperson, Dr. Riya Sagaman sir, and Dr. Ramesh and the team from PhD, and Dr. Abhiramalata, and postgraduates from PhD. So three of us, Nina Priti, and as well as Kriti and Madhumida. I think they really they presented very well. So I think the answering also excellent. They answer very well, and so I really thank each and every one of you, and I thank our judges, today's judges also, Dr. L. Simado, Dr. Srinivasan sir, Dr. Janani Shankar, and PRC sir, because of his personal thing, he could not attend. And really, I thank one and all.